everyone. Welcome to the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by Be Well Texas in collaboration with the UT Health San Antonio Echo program. My name is Angela Riley. My pronouns are she, her, and I will be the facilitator for today's session. A few housekeeping items before we begin. To help us with attendance and to introduce yourself, please enter your full name, affiliation, and email into the chat. Please do remember to stay muted unless you are speaking. We do encourage using the chat and or the raise your hand feature to share perspectives and post questions throughout the session today. If you are having connection issues like me, please privately chat Karen, our awesome Echo IT, for further assistance. And as a note, these sessions are being recorded and will be shared on our website. So therefore, to ensure privacy, no personal health information is allowed during the session today in the chat or in any part of our discussion. At the end of the session, the Echo team will send out a post-session survey, and we kindly ask you to complete it as it provides us feedback on how to refine these sessions to better address your priorities. And finally, Echo is an all teach, all learn environment. We do encourage everyone to participate in the conversation today and raise questions. Let's always make every effort to avoid bias and stigmatizing terms so that we can continue having a space that is respectful and safe to learn. So with that, we'll go ahead and move on into our introductions of our team. We'll begin with Dr. Shorter.
Good afternoon, everyone. I'm Daryl Shorter, and I'm the Medical Director of Addiction Services at the Menninger Clinic, as well as an Associate Professor of Psychiatry at Baylor College
Dr.
of
Shorter, it looks like we can't hear you. Or can we hear you? We can? Oh, we're good. Okay.
Okay. Thanks, y'all. Don't freak me out. I'm about to speak.
Thanks, Dr. Shorter. Dr. Kowalczyk.
Hi, I'm Alicia, Dr. Kowalczyk. I'm an associate professor at Baylor College of Medicine in Family and Community Medicine and boarded in addiction medicine, and I'm medical director for Santa Maria Hospital. Welcome.
Thanks, Dr. Kowalczyk. And we have Dr. Walker. Dr. Walker, once you introduce yourself, please give us a brief announcement. Thank you.
Good afternoon, everyone. Crystal Walker, doctorally trained PA, and I am the Director of Substance Use Services for My Health, My Resources of Tarrant County in Fort Worth, Texas. So I was asked to give a short announcement about a new ruling that just was released from the DEA and Health and Human Services. So last Friday, on January 17th of 2025, there was a final rule released, finally solidifying the information and rules surrounding buprenorphine prescribing via telemedicine. So if everyone didn't know, the temporary rules were set to expire December of 2025. They have now released new rules. Some of the elements have changed, and these are now permanent. So what was changed is instead of allowing only a 30-day supply prescribed via telemedicine and then requiring an in-person visit, they have now expanded this to a total of 6 calendar month supply of buprenorphine through telemedicine visits. They have also removed the requirement that you must have an in-person visit after this. So there are now very flexible telemedicine options for continuing to prescribe your medications, the buprenorphine, to your patients. One of the big changes, though, is in regards to documentation. So for every single prescription, the prescriber must check the Prescription Drug Monitoring Program, or PDMP, for that client in the state that they are in. So if you happen to see somebody in another state, you must check the state that they are in, and you must check it for the last year. Once you have done that, the biggest requirement is you now have to annotate the date and time that you checked it into the chart. Some electronic health records will do this automatically, but not all of them. So make sure that you check with your EHR team to see if when you check your PDMP, it's being recorded. Because if it is not, you have to document date and time that it was checked. If for some reason you cannot check it, you must annotate why, and then you are only allowed to prescribe for 7 days worth. And you can only refill for 7 days until you figure out how to check the PDMP for the last year for that client. I am going to pop about 5 different resources into the chat so that you can read details on your own afterwards. Thank you, everybody.
Thank you so much, Dr. Walker, for that announcement. And so with that, we will go ahead and move on to our didactic presentation for today. Dr. Shorter, you may take it away.
All right, can you see my slides and hear me? Great. So I have the near impossible task of presenting about medications for stimulant and nicotine use disorders in a 20 to 25 minute time span. And anyone who knows me knows that if it can be said in 25 words, that I will take 100 words to say it. So this is going to be quite a feat. The good thing is you will have access to my slides when we are done. And I've tried to include the some reference information so that if there are any studies that you would like to look at a little bit more in depth after this talk, you'll be able to do so. I've also included my information at the end of the talk so that if you have additional questions that you might like to direct to me, you certainly may. I have no disclosures or conflicts. So today I will endeavor to summarize the evidence base for promising medications in treatment of stimulant use disorders, and we'll really be focusing on medications that were recommended as part of the combined American Society of Addiction Medicine and American Academy of Addiction Psychiatry, the combined ASAM AAAP treatment guidelines for stimulant use disorder that came out at the end of 2023. In addition, I'll speak a little bit about medication options that have been under investigation for the comorbid OUD stimulant use disorders, and then I will wrap it up by talking a little bit about management of nicotine use disorder, including some more novel approaches that have been in study over the last few years. So briefly, a psychostimulant is any agent that activates our reward and reinforcement pathways, primarily through dopamine. And one of the reasons that people really enjoy using these types of medications or substances, excuse me, increased alertness, focus, attention, mood elevation, euphoria, and also for some communities to heighten sexual activity and sexual experiences. There are a number of psychostimulants that we could talk about, but for the purpose of today, I'll be focusing primarily upon cocaine and methamphetamine use disorders. I do think it's important to sort of break out MDMA from other substances, as that is a stimulant that is currently under investigation for treatment of psychiatric conditions, including PTSD. I began by talking about the cycle of addiction because it's important for us to know where the patient is or where the client is when they are presenting to us for care, because that might help give us some ideas about the kinds of medications that we might offer to treat stimulant use disorder. So people will typically come in, sometimes they are acutely intoxicated or shortly after they've gone through a period of binge use and they're experiencing withdrawal. An important component of that withdrawal syndrome that someone might experience is negative affect. And this is taken directly from George Koob's work. After a period of withdrawal, people then go into a preoccupation or anticipation phase. And the cardinal symptom or experience that folks have during the preoccupation phase is craving. So when we think about how it is that we might intervene for someone, what exactly are you trying to treat? Are you trying to treat the intoxication phase, the withdrawal phase, or the portion that has to do mostly with craving? So medications for substance use disorders are really intended to do quite a number of things. For some folks, it's really intended to help them initiate an abstinence process. There are medications that block reward or block substances. So we think about medications like methadone, medications like buprenorphine, which really can block the other types of opioids that might be used kind of on top of those medications. We, of course, have medications that are aimed at reducing craving. Think naltrexone for alcohol use disorder. Certainly, it becomes important for us to manage withdrawal syndromes. Aversive therapy, I want you to think about disulfiram or antabuse for alcohol use disorder, which is a type of medication where if someone were to drink on that medication, then they would get sick, creating an aversive experience and perhaps helping that person to, again, initiate abstinence. And then there are a category of medications that really are aimed at changing behavior, both behaviors related to substance use disorder as well as behaviors that are adjacent to substance use, and we'll talk about that today as well. So when it comes to targets for medication therapy for cocaine use disorder in particular, I'm sorry, but before we get there, so where in the cycle of addiction these medication goals are most seen is for binge intoxication. We've got medications that will block the reward experience. For withdrawal, we have strategies for managing withdrawal, medications that can be used in those contexts. When it comes to that period of time, perhaps before craving, we are trying to help someone to initiate abstinence. Then we go on to reducing craving when someone is in that preoccupation phase. Aversive therapy comes before the potential binge or intoxicating experience. And then, of course, the change in behavior can occur at any point during the cycle of addiction. Okay, so now let's dive into this for cocaine use disorder in particular. So it turns out there are a number of medications that have been tried to really focus on sort of the binge or the intoxication phase of things. I do mention a vaccine and immunotherapy, so the cocaine vaccine as well as monoclonal antibodies, where people have been given in clinical trials endogenous or exogenous antibodies to really sort of bind cocaine within the bloodstream and prevent people from experiencing the intoxicating effects of cocaine because cocaine is unable to cross the blood-brain barrier. Now, so just as a kind of thing to like just kind of keep your eyes on, the methamphetamine vaccine is also something that is under active investigation at this time. So, in addition to vaccines and immunotherapy, I do want to focus now a little bit on naltrexone in combination with bupropion. So why naltrexone? I mean, I think we're all familiar with naltrexone from its use in both alcohol and opioid use disorders, but perhaps not necessarily as familiar with its use in cocaine use disorders. Well, it turns out that both on the preclinical as well as on the clinical side, naltrexone has shown a positive signal for reducing cocaine craving as well as cocaine use. It's not a slam dunk of a medication on its own, however. And so, when you're thinking about maybe trying to employ naltrexone in the context of cocaine use disorder, there may be some times, like, for example, if the person also has comorbid opioid use disorder or comorbid alcohol use disorder, then naltrexone may have some positive effect. But keep in mind that the dosing that may be required would be higher than that which we would typically use for alcohol use disorder. And in one study, they went as high as 150 milligrams a day in order to see those cocaine-related effects. Now, that having been said, if the combination of naltrexone and bupropion is something that you might be interested in trying, there has been a recent study that looked at the combination of these medications. And what people reported at the lower doses of the combination with naltrexone at 50 milligrams plus bupropion is that people seem to feel less stimulated by the drug and to like the drug less, although there was no impact on the actual cocaine self-administration. This, I think, sort of lays the groundwork for an interesting consideration of why it is that we might use medications for treating stimulant use disorder. Recognizing that while there are no FDA-approved medications for treatment of stimulant use disorders, so none of the stuff that I'll be talking about today is actually FDA approved, maybe perhaps someone liking a drug a little less or feeling less stimulated makes it a little bit more possible for us to then use some of our behavioral interventions and motivational interviewing to help people make different kinds of decisions related to their substance use. So perhaps fewer options available to us on the intoxication side. But when it comes to cocaine withdrawal and also the negative affect that's associated with cocaine withdrawal, perhaps there may be some additional opportunities here. And naltrexone in combination with buprenorphine, it sort of springs to mind, and that was part of Objective 2 as a potential place for us to manage both withdrawal and negative affect. Well, why is that? It turns out that the combination of naltrexone and buprenorphine, which we don't typically think about, it has you lose the partial mu opioid agonist effect, and instead with that combination you get the kappa antagonist effect from buprenorphine. So buprenorphine is known as both a partial mu opioid agonist as well as a kappa opioid antagonist. But by blocking that mu opioid agonist effect on the naltrexone side, you are just getting only kappa antagonism. And what you see here are there are a couple of groups, and it's fairly obvious from the gray group. The gray group, Group B, is the group that got naltrexone plus buprenorphine in comparison to a group of folks that only got that only got naltrexone on its own. This is was looking at folks that had heroin dependence, but also had cocaine use as well. And what they found, if you just look at the gray bar for me, is that in the group that received both naltrexone plus buprenorphine, that they, over this 12-week experience in the trial, had a significant reduction in their cocaine use. So from this initial study, there was a lot of excitement and enthusiasm about the combination of naltrexone and buprenorphine as a potential treatment for cocaine use within the context of an opioid use disorder. So the CURB trial was then, or the CURB study was then performed, where there was a combination of Suboxone or buprenorphine naloxone along with extended release naltrexone or Vivitrol. Over 300 participants. The punchline here is that when they compared extended release naltrexone plus buprenorphine at 4 milligrams or plus buprenorphine at 16 milligrams versus placebo, while there were no group differences in terms of the primary outcome related to drug screening, there was a significant reduction in cocaine use for the folks that had the Suboxone at 16 milligrams a day in combination with the Vivitrol. So for your folks that may have cocaine use disorder as well as opioid use disorder, thinking about how to implement something like the combination of naltrexone and Suboxone could represent a possible strategy. There have been a number of antidepressant trials that have really looked at how do we treat the negative affect that is characteristic of cocaine withdrawal. And many of you all, especially if you work in our perhaps emergency centers or urgent cares, when you see someone that's coming in with a stimulant use disorder, and they are in withdrawal, they're oftentimes reporting significant depression, perhaps anxiety, as well as sometimes suicidal ideation. And so really targeting those types of symptoms within the context of cocaine withdrawal has been a focus of significant study. But there's one antidepressant that seems to continually sort of get a lot of attention, and I think for good reason, and that's bupropion. Bupropion has shown a potential role in specific subgroups, particularly among folks that might be dealing with the comorbidity of cocaine use disorder as well as major depressive disorder. And again, while this medication isn't necessarily a slam dunk in terms of getting someone entirely to abstinence, what it does create, however, is a reduction in overall cocaine use, perhaps more weeks abstinent, especially when combined with other types of behavioral interventions such as contingency management, and also seeing a reduction in depression, which might make it possible for us to then have some of these other, make some headway with some of these other types of interventions from a behavioral or psychotherapeutic standpoint. So after our antidepressant bupropion, I want to talk a little bit about medications that are aimed at reducing cocaine craving. And again, in addition to bupropion, topiramate, modafinil, mixed amphetamine salts, extended release, as well as lisdexamfetamine, all come under the recommendations that we saw in the recent stimulant use disorder treatment guidelines from ASAM and AAAP. Okay. Topamax or topiramate is a medication that has been studied in cocaine-dependent folks. What you're looking at in this graph is the number or the mean proportion of non-use of days of cocaine. And in the black square, you have the topiramate group in comparison to placebo. And you can see that the topiramate group clearly has a higher proportion of cocaine non-use days. in comparison to placebo. There was increased likelihood of urinary cocaine-free weeks, as well as a reduction in craving. Please note that while they tried, the target dose was 300 milligrams per day, that topiramate was actually dosed to effect. And so if someone was really only able to tolerate 150, 200 milligrams a day, that this particular study made allowances for that. Modafinil, also known as Provigil, was dosed at 200 milligrams a day as well as 400 milligrams a day versus placebo in cocaine-dependent persons. Again, there's sort of a blurring of the lines where the black line at the very bottom is the placebo group. Modafinil dosed at 200 milligrams a day is the orange group, orange line, and then the blue line is modafinil at 400 milligrams. And if you go all the way to the 24th visit, you can see that there's a very clear separation between that blue line at the very end of the trial versus 200 and placebo. And also one of the things that they found interestingly in this particular study was that males tended to be more abstinent. There was a trend toward that. They tended to be more abstinent than females, perhaps suggesting a gender-related response to this medication. There's also the combination of topiramate along with mixed amphetamine salts at the extended release. And so thinking something along the lines of like Adderall XR or extended release. Again, dosed to sort of what we would consider on the higher side, that fuller dose of 60 milligrams a day in combination with topiramate. Again, the treatment group is the one in black. And we are looking at the proportion of patients who participated, who achieved 3 weeks of abstinence. By the end of study, you've got no one in the placebo group being able to achieve 3 weeks of abstinence, but roughly 14% of the folks that received the Adderall XR or mixed amphetamine salts extended release plus topiramate by the end of the study. For those who made any 3 weeks of abstinence during the overall trial, that went up to over 20%. Now, with this particular medication, it does become important to monitor for potential side effects. And so thinking about like the resources that may be available to someone in your particular treatment setting and their ability to kind of follow through with cardiac monitoring might be a factor in your decision making around whether or not to use this particular combination of medication. But importantly, we do also observe with this combination that people report a reduction in cocaine craving. And then finally, amphetamines, and particularly extended release amphetamines, have also been recommended as a potential treatment for cocaine use disorder. So this is looking at lisdexamfetamine, also known as Vyvanse, and they went high dose with this medication as well, offering 70 milligrams a day in comparison to placebo. And again, so that lisdexamfetamine, we're looking at cocaine craving on this particular graph, and you can see that over the course of this 14-week study, that the black squares representing Vyvanse or lisdexamfetamine is going down and is substantially lower in comparison to placebo. People also reporting a reduction in craving, needing cocaine, and then also finding however, that there were perhaps more likely to experience side effects or maybe not even necessarily be retained in treatment. So again, not necessarily a slam dunk, but certainly could represent, along with additional monitoring, an option for patients who are really struggling quite mightily with cocaine craving. So I'll skip over the summary slide here because you will have access to it a little bit later and dive right into our medications for methamphetamine use disorder to again remind us of that cycle of addiction. What is that exactly that we're trying to treat here? And we'll go again for bupropion. So you'll see a little bit of a theme here, both for cocaine as well as for methamphetamine, as well as for nicotine. Bupropion is a medication that has been studied and recommended in really all of these cases. For treatment of craving, we've got topiramate making a return. We've got the combination of bupropion and extended release naltrexone or Vivitrol, as well as methylphenidate, which is the only psychostimulant that I'll be talking about here. And finally, because I mentioned that change in behavior that people can experience as a result of pharmacotherapy within the context of methamphetamine use disorder, I do want to spend a little bit of time just mentioning mirtazapine as well. So bupropion represents an opportunity for us to use a medication that could also have potential effect with treatment of depression as an antidepressant. Also might be potentially helpful for folks that are dealing with nicotine use disorder. But really, when I think about prescribing bupropion for someone with meth use disorder, I'm really thinking about someone that is using less than daily. And as you can see from the bottom chart, it really becomes important that people adherent with the medication and those who are adherent with the medication by the end of the trial, those were the folks who were most likely to experience treatment abstinence by the end of the study. Topiramate again makes another return, again, to 200 milligrams in comparison to 300 milligrams a day, which is what you might see as the target for that earlier study, was the focus of the dose in this trial here. So our orange lines are going to be topiramate. Our black lines will be the placebo group. And what's interesting is that if someone had a negative urine drug screen at the time of randomization in this trial, they were more likely to respond to topiramate. So that's those folks that have the orange line at the sort of the top up here. So while medication did not necessarily increase abstinence during that weeks of 6 to 12 weeks, the topiramate group did reduce weekly methamphetamine urine levels as well as the dependence severity. So when they were looking at the amount of methamphetamine that was in the person's system as a result of urine drug screening, they found that that level actually went down. So people's self-report of using less methamphetamine was actually confirmed by methamphetamine urine levels. Again, creating perhaps a little bit of a window for us to then implement or offer some of these behavioral treatments. Naltrexone plus bupropion has been a subject of great discussion over the last several years. Lots of excitement and enthusiasm around the use of Vivitrol in combination. And it's important to note that when in this particular trial, the ADAPT-2 trial, naltrexone or intramuscular Vivitrol was administered every 3 weeks as opposed to every 4 weeks, which is what we typically do for someone who is receiving treatment for alcohol use disorder or opioid use disorder. That is also in conjunction with high dose or maximum doses of bupropion, 450 milligrams a day. And there have been a couple stages of this trial, and some of the more recent evidence shows that in addition to showing kind of an early separation from placebo, that these findings are sustained from week 6 through 12 in people that are using meth use, people that are using this combination of pharmacotherapy for treatment of meth use disorder. I do want to offer just a quick word about mirtazapine as well. Mirtazapine has been studied particularly in gay, bisexual, and men who have sex with men, as well as cis men and trans men and women, and has been found to reduce not only meth use and certainly the amount of urinary levels of methamphetamine, but also to change behavior, to perhaps reduce impulsivity around sexual practices that may occur within the context of meth use. So when I think about mirtazapine use for folks with meth use disorder, not only are we perhaps targeting the meth use itself, perhaps what we are doing here is we are trying to help people to reduce the number of sexual partners and really some of the decisions that they make around sexual practices and sort of reducing the amount the number of episodes of condomless sex, the number of episodes of condomless sex with serodiscordant partners, and really helping to change the behavior around sex and really allowing us to speak more candidly with patients who might be engaging in sexual practices within the context of meth use and using meth as a way of enhancing those experiences. And then finally, it is important to also note that there can be a reduction in depression as well as an improvement in sleep for folks that are receiving mirtazapine in the context of meth use disorder. Finally, last word would be on methylphenidate. Again, going up to those higher dosages in comparison to placebo, looking at this specifically in meth use. And while there again wasn't necessarily a difference in the number or the percentage of meth positive urines, that people are reporting less methamphetamine use, and they're also reporting a significant reduction in craving. So methylphenidate does make it onto our list as a potential pharmacotherapeutic strategy. So one of the questions that can sometimes come up among clinicians is do I really feel comfortable prescribing a psychostimulant to someone with stimulant use disorder? How do I go about that? Am I, in some ways putting my license on the line by giving someone a medication that is a controlled substance for for meth use disorder or cocaine use disorder. And so one of the things that I often encourage people to think about is what would help you to feel comfortable prescribing this medication? So when we first started talking about the use of psychostimulants for treating cocaine or meth use disorder, we were doing it at a time when there was no prescription drug monitoring program, frankly. But now we are in a time where we can at least confirm that the only psychostimulant prescriptions that our patients are receiving are from us. So, of course, using the prescription drug monitoring program for your state can be extremely helpful in sort of reducing some of the anxiety that people are getting lots of medications from lots of different providers. That's the first thing. The second thing is that perhaps we come up with a strategy within our clinical settings to perform regular routine urine drug screening, and even being able to offer some random urine drug screening to confirm for ourselves, as well as to offer support to the patient to help them to remain abstinent or work toward remaining abstinent, as is often the case. So I think and the final thing that we might consider is more frequent visits. So sometimes when we are perhaps, especially early on with our treatment, when we're establishing a relationship with the patient, giving a 30-day supply of extended release mixed amphetamine salts may feel like too much to do right out the gate. Okay, would you feel comfortable prescribing 7 days and then asking the individual to come back in and do the urine drug screen and check the prescription monitoring program to get a sense of how they're doing on the medication? So is there a way to offer a different kind of monitoring that helps you as the prescriber to feel more comfortable in giving these medications, which now are recommended by two of our very most important addiction related professional organizations. Okay.
Dr. Shorter,
Yep.
so sorry to interrupt. Please excuse the interruption, but we're almost at about time. If we could
I'll
close
wrap
it
it up.
out in the next couple minutes. Thank you.
Thank you. Thank you. Thank you. Okay. As I mentioned, the impossible task. Okay. So you'll have my slides. Couple things. One, there are 5 forms of FDA approved nicotine replacement therapy. You'll see I've got in all caps chew and park. That was one thing that I wanted to make sure that we all continue to remember to remind our patients to chew and park when it comes to nicotine gum. And that we want to encourage the combined use of nicotine patch with another form of a fast-acting nicotine replacement form that actually can substantially increase the likelihood of someone being successful with smoking cessation in comparison to only one type of nicotine replacement therapy on its own. So it's patch and gum or patch and lozenge. The other forms would require a prescription. Bupropion, as I mentioned, is our only medication today that hits all of the substance use disorders that we're talking about, and it is also FDA approved for treatment of smoking. But if you're going to go with a medication, varenicline or Chantix is really where you go. It does have equivalent effectiveness with the combination of nicotine replacement therapy, as well as with e-cigarettes, and it's associated with a higher quit rate than bupropion. So there's been a lot of conversation, I think, about psychiatric symptoms, which you should monitor if someone is prescribed varenicline, but really, varenicline does represent a really important option for us here. I do want to, because I just said this thing about e-cigarettes, acknowledge that it has been discussed that there may be a potential role in treatment as well as in safety or harm reduction. So the addition of e-cigarettes to standard smoking cessation actually resulted in greater abstinence in this one recently published study. And also it appears that secondhand vapor may be relatively safer. I want to acknowledge relatively safer than secondhand smoke in terms of nicotine absorption in children. And then finally, just a quick word about cytosine or cytisinicline, which is a kind of European over-the-counter version equivalent of varenicline that has been studied and has been discussed quite a bit in the literature more recently, and may also hold some promise. Okay, I'll go ahead and stop there and stop sharing my slides so that we can move on to the case.
Thank you, Dr. Shorter, for that wonderful presentation. And I'm so sorry to have interrupted you, but anyways, I do want to highlight that there are a couple questions in the chat, but I will bring one forth for a quick Q&A after your presentation, Dr. Shorter. So Lindsay asked, why would they give a lower dose of topiramate, and please excuse me if I butchered that, for meth than cocaine? So if you can answer for us,
Yeah, I
please.
think that's just what they ended up studying for that particular trial. I can tell you that, like, just sort of anecdotally, and this is, so please take it as anecdotal evidence, getting people above that 200 milligram a day dose can sometimes be a little bit challenging because people are sometimes maybe experiencing side effects from it at greater than 200 milligrams a day. Things that people get very concerned about are symptoms like cognitive dulling or feeling a little bit uh, uh, like that just now, the thing I just did, that would be a great example of cognitive dulling. Um, so, so monitoring for side effects becomes very important with that particular medication, which is why they have allowed so much flexibility in how much someone is. Thank you, brain fog. I appreciate you so much. Why they allow so much flexibility in the amount that someone is dosed during the clinical trial. So if someone gets to 100 milligrams a day and that's really all that they can tolerate, then so be it. They stop there and they allow that person to continue at that dose for the remainder of the trial.
Thank you, Dr. Shorter. Lindsay, I hope that gave you an answer to your question. So in the interest of time, we will go ahead and move on to announcements. However, Dr. Shorter, I would like to point your attention to the chat in case you can answer some of those questions. Karen, whenever you have a moment, please, if I could see the slides. Just giving Karen a moment. If you haven't already, please go ahead and enter your name, affiliation, and email into the chat to introduce yourself and for attendance. Thank you, Karen. So to claim your CME credit, you must text attend 100-98219 to the number on the screen, 844-502-1338 by midnight tonight. Next slide, please. The 2025 Texas Substance Use Symposium is still open for registration. It will take place from February 27th to the 28th in El Paso, Texas. This free event will feature complimentary continuing education curricula, interactive panel discussions, and professional networking with national and Texas-based substance use disorder experts. So to register today or tomorrow, please visit the link in the chat. Next slide, please. Texas US 2025 is still open to receiving sponsors and exhibitors. If you are interested in learning more on how to become a sponsor or exhibitor, please visit the site that will be shared in the chat. Next slide, please. Thank you. Please join us for our next session on February 13th with Rachel Cooper for a session on what works and why, strategies to reduce substance use disorder stigma in healthcare settings. Thank you, Karen. And so before we move on to our case, I would like to give the opportunity to two of our hub members to introduce themselves. Dr. Weems.
Hey everybody, I'm John Weems, internal medicine doc and addiction specialist. I help run a primary care FQHC-based addiction medicine clinic here in Austin. Welcome everybody. Honored to be part of the team.
Thanks, Dr. Weems. Dr. Chowdhury.
Thank you so much. Hi, my name is Ali, and I am an adolescent addiction medicine physician working to establish a multifaceted adolescent addiction medicine program here in San Antonio. And I'm learning a lot from this TxRx Echo.
I think it's safe to say something new is learned every session. So thank you all for being here. And I would like to also have have our case presenter introduce themselves, but before they do, just a reminder to everyone that no protected health information is allowed in the chat or discussion, especially during this part of the session. And let's continue making the space inclusive and open to respectful dialogue. So with that, our case presenter, you may take it away.
Hi, everyone. My name is Daniel Hendayan. I'm a faculty member at DTAR Family Medicine Residency Program here in Victoria, Texas. I'm also addiction medicine fellowship trained. Did my fellowship training in Memphis, Tennessee. Also did my family medicine residency here at DTAR. So I came back and joined up with the team down here. So I have a case here. This is a 57-year-old male, Hispanic male, who I've been seeing since I was a resident. So it's come full circle for me down here. Some questions that I wanted to be addressed are, what are some effective community outreach strategies to address the limited kind of patient resources we have in these type of rural settings? A lot of people don't know where Victoria, Texas is. We're kind of going towards the coast. We're about 30 minutes away from the coast, Port Lavaca, called the Golden Crescent. We're surrounded by Houston to the north, San Antonio, and Austin to the west. Another question I had, what are the available treatment options for stimulant disorder in these types of rural settings? Been seeing a lot of stimulant use, especially patients who are admitted to the hospital, patients who have been referred now to our residency-run addiction medicine clinic. And then what placement options exist for patients with comorbid conditions in these types of rural settings. So going back to the case, this individual had used cocaine in the past, but now his substances of choice, as you may say, include heroin and methamphetamine. So as you can see, methamphetamine use is current. He has a long history of methamphetamine use and a long history of opioid use, particularly heroin, both via insufflation and intravenous use. Denies any other substance use per se that has been significant. So for a primary substance use disorder, opioid use disorder, and secondary substance use disorder, stimulant use disorder, both categorized as severe. He has also co-occurring psychiatric diagnoses. He follows up with one of our local behavioral health facilities here in town, which supplies for the region. So he has diagnosis of schizophrenia and PTSD, which is placed in his, noted in his chart. So some medications he's tried for substance use disorder in the past include methadone, Suboxone. Presently, he is on Suboxone, sublingual films, 3 a day of the 8 mg film, so 24 milligrams per day currently. In the past, he has been in inpatient behavioral health facilities. Most recently, I believe, was, I'll say, over a year ago. And we have substance use counseling, which he has done in the past. He's been referred to our local recovery outreach center here in town. And mutual support groups, he has not really identified any support groups that he's tried or has really helped him in the past. So some harm reduction services that we have offered here in our clinic, which initially started as just he was seen as a patient in our family medicine continuity of care residency clinic. And then now currently in our resident run addiction medicine clinic, naloxone and referral to a local recovery outreach center. Some social conditions, psychiatry history, Very significant, I would say, would be family, other individuals who he lives with, friends, all of whom use different types of substances. Several family members and friends who has told me has passed from overdose. He lives in an apartment here in town that I believe is funded by one of the local housing authorities here in town. But he lives with friends as well. Those who also, he has admitted, who use different substances. Currently unemployed. Um, and we checked the PDMP at each visit. So current findings, he is fairly compliant with Suboxone. We do urine drug screens at each visit. That is present. We also send him out for confirmatory testing that's present as well as metabolites in the urine. In addition to that, methamphetamine is also present in his urine drug screens and confirmatory studies. So current medications, he is on Suboxone, 8 milligram films. Sorry, that's supposed to say 24 milligrams daily. That was a typo. For opioid use disorder, he is also on duloxetine, 6 milligrams daily, Seroquel, 300 milligrams daily, and trazodone at night. Some of their medical comorbidities, history of hepatitis C, opioid disorder, stimulant disorder, major depressive disorder, generalized anxiety disorder, schizophrenia, chronic pain, as well as multiple admissions to our hospital here in town for abscesses, both upper and lower extremities. Most recently, about 3 months ago, he developed compartment syndrome. One of his left arms had to go for fasciotomy and debridement. The good news is that we were able to save his arm. So current treatment plan, he continues to come in pretty regularly, misses an appointment every now and again. But he comes into our family medicine residency clinic for his chronic medical conditions for follow-up, and then also comes into the addiction medicine clinic at our residency clinic for continuation of his Suboxone. And he also continues to go to our regional behavioral health center for psychiatric services. So when I was writing this, he was currently in a skilled nursing facility for wound care of his left arm after his last hospital admission. While he was there, we were able to continue him on Suboxone films, which in a sense was a feat to have the skilled nursing facility administer that to him. And he was discharged from the skilled nursing facility. We saw him last week in our residency clinic just for discharge follow-up. And then he was able to follow up with myself and some of the residents in the addiction medicine clinic, which we have every Friday, 3 times a month down here. So last visit, he did endorse that he had returned to use. He is not using via injection. He's using via insufflation at this time, but also still continues to use methamphetamine, which he says he also uses via insufflation, and continues to take his Suboxone as prescribed.
Thank you, Dr. Hindayan. Thank you so much for presenting this case. I'd like to open up the floor for discussion. Are there any questions from the audience, whether it be team or community members?
So I know one of your questions was about resources, especially being kind of in a more rural area and things of that nature. So this is a tidbit for you as well as everyone else on the call. But if you don't know, the state of Texas has something called OSARs, and we're divided up into regions. And there's a local mental health authority assigned to each region. And that is the designated OSAR, which stands for Outreach, Screening, Assessment, and Referral. And that very specific organization is going to have all of the resources known in your area for substance use treatment of various degrees. I believe Victoria is in either Region 8 or Region 11, but I'll pop a little thing in the chat and you can reach out directly to your region's OSAR to get additional resources for someone. And then specifically in regards to mental health stabilization, there are crisis units also embedded into LMHAs in several in the state of Texas. So I'll put that in the chat as well because they do get additional funding for a certain allotment of psychiatric beds specifically for crisis stabilization. So I know your patient has kind of two main issues going on with the psychiatric component and the SUDS component. So I'll put both of those resources in the chat.
Thank you.
Thank you, Dr. Walker. Any other questions? Dr. Shorter, I know in our earlier discussion you had mentioned talking about what the community around the patient looks like, or perhaps any support from that angle.
So yeah, this is one, my hats off to you for such tremendous work with an incredibly complicated situation for this gentleman. As you were going through the case and we were reviewing it ahead of time, I was really struck by the significant psychiatric comorbidity that is present for this individual. We're not talking just about the presence of opioid use disorder and stimulant use disorder, but also a trauma-related disorder, as well as schizophrenia or a psychotic illness. In our pre-discussion, we were also kind of thinking about whether or not this was a stimulant-induced psychosis, if it was schizophrenia, if it's schizoaffective disorder because of the presence of a depressive disorder diagnosis, so really psychiatrically complicated. The good news is, and if I can give kind of a thumbs up, the use of quetiapine for stimulant-induced psychosis is actually supported in the literature, and it seems to have sort of a similar type of efficacy as other medications like olanzapine, which would be another stimulant-induced psychosis recommendation from an antipsychotic standpoint. So continuing to sort of optimize that medication for better control of psychosis, as well as perhaps mood stabilization. We do use Seroquel or quetiapine for antidepressant augmentation. So if there are symptoms of depression that are present, in a higher dose of quetiapine might also be helpful here as well. I was thinking about the role of trauma-focused therapy and sort of thinking about well, how do you maybe provide those types of services for people? And so I really appreciate Dr. Walker's recommendations or advice along those lines related to OSAR and other types of community providers that might be able to offer treatment-focused psychotherapy. The other piece in here that I think is a stressor is that you mentioned that he's staying with friends, and I'm wondering if there isn't a housing component that might be adding another sort of social or structural determinant of mental health that is contributing to this overall stress and could explain perhaps the recurrence of methamphetamine use in the context of stabilization on Suboxone. Obviously, being unhoused or experiencing sort of an unhoused status can be a tremendously stressful experience for folks. And also, I'm kind of interested in understanding the recovery environment and sort of access to substances within that living space. Now, of course, if this is the only place that he's got, then you just kind of got to work with it and then maybe think about well, how can we help to kind of keep you safe within that environment? And then the final thing I'll say based on the talk today is that you have a number of medications that could be potentially offered for targeting the methamphetamine use disorder. Even before you go directly to the psychostimulant methylphenidate, you've still got topiramate that can be offered. You've still got mirtazapine that could be offered as well. And one of the things that I kind of think about when it comes to medications is I love starting a medication for someone, and even if it doesn't work, I invite people to come back and tell me, Shorter, your medicine did not work. I'm like, great. At least that you came back, right? Like we are creating a little bit of a sort of deepening our treatment relationship, um, offering additional opportunities for establishing rapport, and ultimately helping to retain people in treatment. And sometimes that is like the best thing that we can do, just retaining people in care so that sort of the magic and the miracle can happen for them just because they have, sort of keep coming back to care. So I'll stop there because I know that there's a hand raised, but great job on this case.
Thanks, Dr. Shorter. Yes, Lindsay.
Yeah, so I'm wondering what this person's purpose is, right? Have you had that discussion about like what are their goals, what are their hopes, like what do they want to do? Why are they here? Because I know that that's been a huge issue with a lot of the people that I work with, especially with the, the low motivation, things like that happen with the stimulant use disorders. Like just finding community and purpose for somebody can be life-changing.
Yeah, since I've seen him now, I want to say about it's been 4 years. And I kind of get the sense where he's kind of just stuck in this cycle, and he's and I guess being in Victoria doesn't really help help much. But it's kind of just stuck in a cycle. He's had all these family members and friends who have passed from overdose. His wife, I remember when I was a resident, he had come in and told me his wife had recently passed from an overdose. Um, so I'm hoping I just one day I just break that cycle. It's kind of what I'm just hoping for, and I kind of try to talk with him and see, what do you do for your day to day and that kind of thing. And he's not really too upfront with me with a lot of stuff, and he just a lot of times he comes in, we're like, hey, what's going on, man, that kind of thing. So it's tough to kind of get a real good sense of what his goals are, but I feel like in a sense where he's just kind of stuck. Um,
And just to highlight Lindsay's comment, peer support could really be useful here, bouncing off ideas off of life experiences and motivation and motivating one another. That really goes a long way. In the interest of time, I would like to pass the mic back to Dr. Shorter to give us a brief summary of recommendations.
Yeah. So this is a gentleman with multiple psychiatric and medical comorbidities, diagnoses of opioid use disorder, stabilized on buprenorphine medication for opioid use disorder, as well as an active methamphetamine use disorder, in addition to psychiatric diagnoses of schizophrenia, depression, PTSD. Currently taking medications for those conditions, but there represent a number of opportunities to further optimize his medication regimen, which could include one, well, further work with the antipsychotic medication, which might have the additional benefit of helping not only the psychosis, but as well as the depression, and then also the use of medications for stimulant use disorder, as outlined today. Getting this gentleman connected with peer support, which I love that as a recommendation, as well as trauma related, and perhaps even grief, as you were talking about the loss of his wife, grief related psychotherapy might also be helpful for him, in addition to exploring options for housing. So number of things that represent opportunities to engage him.
Thank you, Dr. Shorter. Thank you to our case presenter for today. Thank you to all that participated. We're so grateful for everyone. As a reminder, to earn CE credits, please text attend 100-98219 to 844-502-1338 by midnight tonight. And we kindly ask that you complete the post-session feedback survey using the link in the chat. We look forward to seeing everyone at our next session on February 13th. Have a great rest of your day. Thank you, everyone.